Go ahead, ma'am.
Good afternoon, everyone. Myself, Dr. Shweta Sonwalkar, Clinical Head and Fertility Specialist at Oasis Fertility, Belagavi. Today, I am talking all about adenomyosis. Before starting everything about adenomyosis, let us understand how the uterus is made up of. There are three different layers of uterus, that is endometrium, which is the innermost layer of the uterus, and myometrium, that is the middle layer of the uterus, and it is made up of muscle layers, and outermost layer is perimetrium. So what happens in adenomyosis? Adeno means glands and meiosis means muscles. So the cells that typically coat the interior layer of the uterus, that is endometrium, when it penetrates into the muscle layer, that is myometrial layer, and resulting in the enlargement of the uterus, is known as adenomyosis. So how what is the prevalence of this adenomyosis? It almost ranges from 5 to 70%, and women younger than 40 years, 20% of prevalence is there. And in the woman aging between 40 to 50 years, 80% prevalence is found. Then how this adenomyosis occurs and why it occurs? So there are four theories on the mechanism of adenomyosis. That is invasion of endometrial basilis into the myometrium and microtrauma of the junctional zone, which causes endometrial tissue to enter inside the myometrium, and de novo metaplasia from stem cells, outside to inside invasion induced by the trauma. What are the risk factors? That is in whom this adenomyosis is very common. It is more seen in increasing parity. That is the person who has delivered one or two times, then early menarche girls, then short menstrual cycle, a patient who has a history of cesarean section, then endometrial curettage or evacuation, and some of the drugs like antidepressant drugs and tamoxifen because of estrogen agonistic action. Adenomyosis is same. Then, what are the symptoms of this adenomyosis? That is, woman suffers from abnormal uterine bleeding, that is in the form of heavy menstrual bleeding, sometimes prolonged menstrual bleeding, then intermenstrual bleeding, that is in between the menses, spotting or bleeding will be there, then premenstrual spotting. Sometimes patient may complain gynecological pain symptoms, that is dysmenorrhea, pain during the menstruation, then dyspareunia, pain during the intercourse, and chronic pelvic pain, that is lower abdominal pain. Then it causes infertility and recurrent miscarriages, then local pressure symptoms, that is this pain during urination, pain during defecation. So, what are the how the frequency with the pain is related? Is 77% of the frequency we see chronic lower abdominal pain, and in 40 to 50% hypermenorrhea will be there. Then in 15 to 30% of the patient we see dysmenorrhea, that is pain during menstruation, and 30% of the patients are asymptomatic, and dyspareunia we see in 7% of the patients, and infertility is seen in 7 to 28% of the patients. Then how this adenomyosis causes infertility? Because of the altered uterine contractility, then oxidative stress environment, thickening of the junctional zone, anatomical distortion, and macrovilli damage, abnormal steroid metabolism, then which all leads to impaired fertilization and impaired implantation, leading to miscarriages. Then how do we diagnose this adenomyosis? The gold standard is invasive histology and non-invasive is transvaginal sonography and MRI. Transvaginal sonography, it is the first line imaging technique. Here we can see spherical enlargement of the uterus with an asymmetrical thickening of an anterior and posterior. Sensitivity of this transvaginal ultrasonography is 92% and specificity is 75%. So when we do a ultrasonography, there are different features we can see in the ultrasound. So these are the schematic diagrams which is showing asymmetrical thickening of the anterior and posterior wall. Then we can see cysts, then hyperechoic islands, fan-shaped shadowing, then echogenic subendometrial lines and buds. Then we can see transvascularity, then irregular junctional zone and interrupted junctional zone. And when we do a Doppler study, we can see translesional vascularity. So there are different types of adenomyosis, that is focal adenomyosis, where the lesion is localized, and diffuse adenomyosis, where the lesion is, we can see in anterior posterior wall, it is diffusely spread, and sometimes adenomyoma. So severity of adenomyosis may be classified according to Musa to the extent of the disease into mild, moderate, and severe. If the lesion is less than 25% involvement, that is mild, 25 to 50% involvement, we call it as moderate, and more than 50% involvement, we call it as a severe. Then second line of examination is MRI. So MRI is indicated in cases of inconclusive ultrasound evaluation or as a preoperative measure prior to surgical intervention. In MRI, it distinguishes between subtypes of adenomyosis and more precisely differentiate between adenomyosis and fibroids than transvaginal ultrasonography. The junctional zone fluctuates in thickness depending on the hormonal levels. So hysteroscopy, we can see the different signs which suggests adenomyosis. It may be such as endometrial hypervascularization, strawberry pattern of the endometrium, endometrial defects, and submucosal hemorrhagic cysts. So what are the different modes of treatments? Treatments mainly depends upon age of the patient, symptom severity, and desire for future conception and associated comorbidities. Adenomyosis usually regresses after the menopause. So non-surgical, medical or interventional therapy. If the patient's symptoms such as if the patient is suffering from heavy or painful periods can be controlled with hormonal treatments such as OCPs, Danazol, Dinogest. Danazol is not used much now. Then Dinogest, levonorgestrel IUCD for 3 to 6 months. Then GnRH agonists, aromatase inhibitors, and ulipristal acetate. Other treatments are uterine artery embolization, then magnetic resonance guided focused ultrasound surgery. Then uterus sparing surgical treatments such as endometrial ablation and adenomyomectomy, either laparoscopic or hysteroscopic adenomyomectomy. Then what we do in endometrial ablation? Endometrial resection is effective and it is indicated in the patients with adenomyosis, which is limited to junctional zone and allows a reduction of heavy menstrual bleeding. It is contraindicated in patients who wants to conceive because the disadvantage being it causes distortion of the uterine cavity, then high recurrence of symptoms due to insufficient cauterization. Destruction of this junctional zone in endometrial ablation causes serious complications, which leads to miscarriage, preterm labor, and placental complications. That's why it is indicated only in patients who already has issues. Then uterine artery embolization. It has got a very limited success, and so it has a limited use only in post reproductive age. Here, the embolization causes closing of the vessels that supply the uterus by injecting polyvinyl alcohol particles or gelatin sponge into the catheter placed in the femoral artery. It can affect both hormonal production and ovarian reserve, leading to premature iatrogenic amenorrhea and infertility. Then hysteroscopic surgery. Hysteroscopic adenomyotomy is possible in selected cases, especially when the adenomyoma is less than 5 cm or when it protrudes into the uterine cavity. So, pre-treatment with 3 months of GnRH agonist may help to reduce the vascularity and bleeding during operation. Sometimes it may also help to push the adenomyoma towards the uterine cavity due to reduction of uterine volume. So these are the different modes of treatments. And how about fertility? That is, if the patient does not conceive and if the patient wants to go for IVF treatment, then GnRH analog therapy before IVF for 3 to 6 months is needed, and its side effects being menopausal symptoms, that is hot flushes, dryness of the skin and all. And so add-back therapy with calcium is required in these patients. Then regarding stimulation protocol, long GnRH analog protocol should be considered, and two-stage IVF, that is oocyte pickup, and then freeze the embryos. Then next do frozen embryo transfer with HRT protocol. Then single embryo transfer is preferred as adenomyosis is associated with increased incidence of preterm delivery, preeclampsia, and second trimester miscarriage. Thank you. Any queries? I am free to answer. How can you confirm adenomyosis? Adenomyosis is confirmed first by taking the history. If the patient is having abdominal pain, then dysmenorrhea, heavy menstrual cycles, and after eliciting the history, we usually do transvaginal ultrasonography to confirm whether adenomyosis or any other pathology is present. Next, how can I cure my adenomyosis? Adenomyosis, once it is diagnosed, we usually go for medical line of treatment, and we give medications, hormonal therapies to reduce adenomyosis. And if adenomyosis is focal or diffuse, then depending on the type of adenomyosis, we treat even surgically, and that is the cure. Then complete cure is usually not possible with hormonal medications. Next, can I conceive with adenomyosis? Yes, you can conceive with adenomyosis, but treatment depends on the severity of the adenomyosis. Again, I am telling. So, depending on the severity, mild, moderate, or severe, we treat accordingly with medical or hormonal or surgical treatment. And with hormonal treatment for 3 to 6 months, at least shrinkage of the adenomyosis will occur, and by giving ovulations, that is tablets to um, get good follicles, then you can go for IUI also, but you can conceive with adenomyosis also. Next, thank you.